I'm Dr. Jeff Donovan. I'm a dermatologist, and it's my pleasure today to speak to you about scarring alopecia. This is the second module on hair loss, and if you haven't reviewed the module on non-scarring alopecia, this would be an appropriate time to do it. Today we'll be focusing on scarring alopecia. I don't have any conflicts of interest or disclosures about this particular module. What are the learning objectives? Well, this particular lecture is designed to meet these learning objectives. I'd like to help you differentiate among three common scarring alopecias: lichen planopilaris, central centrifugal cicatricial alopecia, and folliculitis decalvans. So how do we diagnose hair loss? Well, there's over 100 reasons to lose hair. We divide these into scarring and non-scarring. We've discussed scarring in this lecture. Non-scarring hair loss conditions were discussed in the previous lectures. Whenever I see a patient with hair loss, I try to determine whether they fit in a non-scarring group or whether they fit in a scarring group. Non-scarring conditions were discussed in a previous module, and these include conditions like alopecia areata, telogen effluvium, and androgenetic hair loss. When I look up close on the scalp of someone with a non-scarring alopecia, I see the hair follicle openings, or the pores. In contrast, when I look up close with a patient with a scarring alopecia, the scalp is smooth, almost like a skating rink. These hair follicle openings are not present, and that gives me a clue that this patient may have a scarring alopecia. And we're going to talk about that in these modules. In scarring alopecia, the important point that I'd like you to remember is that regrowth is not possible. We can sometimes stop the condition and stop it from getting worse, but regrowth is usually not possible. And that differs from the non-scarring conditions, where we can often regrow the hair to some extent with treatment. Let's talk about lichen planopilaris. This is one of the scarring hair loss conditions. Then we're going to talk about central centrifugal alopecia, and finally we're going to talk about folliculitis decalvans. But let's start with lichen planopilaris, or LPP. Patients with LPP may have hair loss for many years. But the important thing I'd like you to always remember is that these patients have itching, and some have burning, and some have pain. They're very uncomfortable. The scalp may feel on fire, and it's not uncommon for a patient to describe that they put ice on the scalp to make it feel more comfortable. I'd like you to review this quiz question and then pause and give thought to the most appropriate answer. Which symptoms are often present in patients with lichen planopilaris? A. Scalp itching. B. Scalp burning. C. Scalp pain and tenderness. Or D. All of the above. Pause now and give thought to the answer. The answer here is D. All of the above. And this is such an important concept for this module, that when patients describe to you that they have itching, burning, or pain, they have symptoms in the scalp, please consider a scarring alopecia. The other way of saying that is please consider a scalp biopsy. This can often catch the diagnosis of a scarring alopecia, even if it doesn't look like a classic scarring alopecia. These patients are symptomatic. Lichen planopilaris, what do we see on exam? Well, when you look at the scalp, you see that there is diffuse hair loss. There may be hair loss from the front, from the middle, from the back, from the sides, but in lichen planopilaris, the center of the scalp is often affected. The scalp is often red, and when you look up close, you may see white scales around the hair follicles as well. But as we said in previous slides, when you look up close, these hair follicle openings are gone, and the scalp appears very smooth, like the skating rink analogy that I used previously. What is the cause, and how common is it? Well, lichen planopilaris is not common. It's not as common as genetic hair loss or alopecia areata. Maybe 1 in 10,000 patients will have LPP, but in a dermatology clinic, it's something that's seen from time to time. It's important for you to identify it because you may help this patient alleviate their symptoms. You can stop their itching, you can stop their burning, you can stop their pain, and you can also stop their hair loss as well. So what's the cause? We don't fully know the cause of lichen planopilaris, but we believe it to be autoimmune in nature. In scarring alopecias, the inflammation is high up in the hair follicle. And on the right side of this diagram, you can see the inflammation around the middle of the hair follicle. This is where the stem cells live. And it's for this reason that we know now that inflammation in scarring alopecias destroys these stem cells, and that leads to permanent hair loss. Regrowth is not possible in most patients with scarring alopecia, and that's such an important concept for this module. Let's take a closer look at this. In alopecia areata, which we discussed in a previous module, the inflammation is at the bottom of the hair follicle, which we call the bulb. The stem cell region in the middle is unaffected, and so if we can get rid of this inflammation with treatment, the stem cells are still present and may allow a new hair to regrow. In contrast, in scarring alopecia, the inflammation is in the middle. The inflammation overlies this area where the stem cells reside. This leads to destruction of these stem cells, and this limits the patient's ability to regrow hair. Lichen planopilaris shows whitish scale around the hair follicles, and in this diagram you can see whitish circular scale around these hair follicles. We call that perifollicular scale. There may also be scale in other regions of the scalp as well. There may be redness in the scalp, and there may be redness around the hair follicles. That's what we call perifollicular redness, or perifollicular erythema. But the classic concept to understand is that the hair follicle openings are lost. Lichen planopilaris, which you'll learn in other modules, may be present on other regions of the body. Lichen planus may be present in the mouth, on the nails, or on the skin, or there may be genital lichen planus as well. How do we treat lichen planopilaris? The key concept is that any anti-lymphocytic treatment is likely to benefit somewhat in lichen planopilaris. We classically use steroid lotions and creams or steroid injections to deliver these anti-inflammatory treatments right to the hair follicle. Oral medications may also be used, and we often start with medications like hydroxychloroquine or the tetracycline family or cyclosporin or mycophenolate. These are oral immunosuppressive medications which can be helpful in LPP. Hair transplantation may be possible to help bring back hair to the patient, but this is only possible if the patient's LPP is quiet for a period of 1 or 2 years, meaning that they haven't gone on to lose more hair. It's only then that we can attempt a hair transplant. The second scarring hair loss condition that I like to describe is central centrifugal cicatricial alopecia. And it may be obvious that we abbreviate this to CCCA. It's much easier to say than central centrifugal cicatricial alopecia. This is one of the most common scarring alopecias in black women. And in fact, 10 to even as high as 30% of women with afro-textured hair may have CCCA. And so I would encourage you to consider this diagnosis. In any woman with afro-textured hair that comes to see you with concerns about hair loss in the middle of the scalp, this patient may have CCCA. We don't fully understand the cause of CCCA. We believe that there may be many things that cause trauma to the hair follicle that lead to CCCA. This may be prior relaxing. It may be cornrowing, weaves, or braiding of hair, especially at young ages, which sets the scalp up for this inflammatory reaction that then leads to the scarring process, which then leads to CCCA. This remains debated. Patients with CCCA may not have any symptoms. They may simply come in and describe hair loss in the center of the scalp, and that's why CCCA is so important for you to recognize. It's a lymphocytic scarring alopecia, meaning that there are lymphocytes in the middle of the hair follicle which are destroying those stem cells. And the treatments are similar to LPP, steroid injections, topical steroids, and medications like the tetracycline family are commonly used in CCCA. The final scarring alopecia, which I'd like you to understand in this module, is folliculitis decalvans. Patients with folliculitis decalvans often describe itching and burning and pain. These are common symptoms in any scarring alopecia. Patients may describe pus and blood drainage from the scalp as well. And the top of the scalp is a common site, which is the area we call the vertex or the crown. And when you look up close to the scalp in someone with folliculitis decalvans, you will see an interesting finding, which we call tufting. In tufting, the hair follicles fuse together. Instead of one hair follicle coming out of a pore, or 2 hair follicles or 3 hair follicles, in folliculitis decalvans you see tufting, meaning that 10, 15, or even 20 hairs have fused together on account of the inflammation, and they emerge from a single hair follicle opening, almost like a doll's hair. That's called tufting. Patients may have pustules when you look at the scalp. They may have crusting, they may have tufting, which we described in the previous slide. And when you swab the scalp, when you swab these pustules, they often grow bacteria, especially Staph aureus. I'd like to pause for this quiz question, which helps you understand a little more about folliculitis decalvans and some of the important things that you should ask on history. A 32-year-old male has itching, burning, and several bumps in his scalp. He occasionally wakes up with blood on his pillow. What diagnosis must be ruled out? A. Genetic hair loss. B. Alopecia areata. C. Folliculitis decalvans. Or D. Lichen planopilaris. Hit pause now and give thought to this question. This is a challenging question, and the appropriate answer is C. Folliculitis decalvans. Patients with folliculitis decalvans frequently wake up with blood on their pillow, and that's a very important question to ask a patient with potential scarring alopecia. Patients with lichen planopilaris, option D, also have itching, burning, and bumps in the scalp, and so you weren't wrong to at least consider this. But waking up with blood on the pillow is not common in lichen planopilaris. This is a scarring alopecia. This patient has itching, this patient has burning, the scalp is uncomfortable. He has bumps, he has blood on the pillow. This is folliculitis decalvans. Folliculitis decalvans often grows bacteria. Staph aureus, as I mentioned, is a common cause as well. Treatment often involves antibiotics, often long courses of antibiotics. And when the swab comes back from the lab, we look at what the cultures and sensitivities are, and that is the antibiotic that we prescribe. This patient was given cephalexin, and after 6 weeks, you can see that the redness in the scalp has improved, the pustules in the scalp have diminished. But the important concept in scarring alopecia is that the vast majority of the hair that has been lost is lost permanently. Hair loss is divided into scarring and non-scarring forms. This particular module focused on the scarring alopecias. The non-scarring forms, which I reviewed in a previous module, may have the potential to regrow with treatment. The scarring hair loss conditions, like lichen planopilaris, CCCA, and folliculitis decalvans, usually lead to permanent hair loss, and treatment helps alleviate symptoms and helps prevent further hair loss. By now, you should be able to differentiate among these scarring hair loss conditions and how they differ from some of the non-scarring conditions that we reviewed in a previous module. I hope you enjoyed this module. Thanks for listening.